right. Good afternoon and welcome everyone. Happy New Year. Uh, this is our first grand rounds for this calendar year for 2026. And I could not have asked for a better way to begin this year than to have a star joining us for our grand rounds today. It is my great pleasure and honor to introduce Dr. Gideon Smith, Chair of Department of Dermatology here at Macon and John Brock, Virginia Health Sciences, Eastern Virginia Medical School at Old Dominion University. I hope I got it right. I was practicing. Dr. Smith's professional journey is as remarkable as it is unconventional. He is a native of Great Britain. He began his academic career not in medicine, but in physics. He did his PhD in theoretical geophysics from University of Leeds. And then he went on to teach and conduct research both at Harvard and then at Washington University in St. Louis. As an academic geophysicist, he was highly successful and was supported by National Science Foundation funding to do some really fun things, at least I think, like, for example, studying the seismological structure of Tonga slab, and then earthquake signals in Antarctica and similar sort of things. So, when I was going through your CV, and I think this is the third time I'm going through your CV. It always excites me, all these fun things that you did. And at some point, and I'm sure wisely, Dr. Smith decided that medicine might be even more interesting. And so he went on to earn his MD from Cornell Medical College in 2007, did his internship in internal medicine at Beth Israel Medical Center in New York, and then a dermatology residency at NYU Langone Medical Center. And so there he also completed and his specialized training in connective tissue diseases and scleroderma as a Sulzberger Fellow. After fellowship training, he joined the faculty at Harvard Medical School and Mass General Hospital, where he founded their connective tissue diseases clinic and rose through the ranks to become vice chair of dermatology before we were able to successfully recruit him here and attract him here to EVMS. He holds an MPH also from Harvard School of Public Health and is also a graduate of Physician Leadership Development Program at Mass General Hospital. So Dr. Smith is an exceptionally productive and influential scholar. He has authored more than 120 peer-reviewed publications in leading journals such as Science, lots of dermatology and rheumatology leading journals, and he has contributed over 20 chapters to leading textbooks in dermatology. His research spans across the pathogenesis of scleroderma, development of new therapies for psoriasis, and issues related to public health, quality improvement, and patient safety. He serves on multiple national committees within the American Academy of Dermatology and the American Board of Dermatology, helping to shape standards of care and training, and his work has been recognized with several national and international awards. Now, from all this, it is clear that Dr. Smith is a true quadruple threat, a superb clinician, a clinician educator, clinician scientist, and an academic leader. But there is an additional dimension to his life that is less commonly found in academic medicine. Dr. Smith is also an accomplished, award-winning writer of fantasy and science fiction. Just last year, he received a Bion Fantasy Award, and he actively mentors others also in the craft of speculative writing. So rather than calling him a quintuple threat, now that there is another dimension to it, I think it's more fitting to describe Dr. Smith as a modern day Renaissance scholar, someone who has excelled in hard sciences, in medicine, as both medicine is science and art, and also in creative literary expressions. So please join me in giving a warm welcome to Dr. Smith.
Thank you, Dr. Kayan. Thank you all for the welcome. It is my great honor to be here today. It is also a pleasure to be here at EVMS. The welcome I've got from everyone has been wonderful. As Rehan just said, I spent the last 15 years of my professional career up in Boston at Harvard. And whilst I was there, my career was really divided into two broad areas, one of which was doing public health research, working a lot in quality improvement and patient safety. The other part of my clinical activities was, as was mentioned, founding the Rheum Derm Clinic at MGH, where we developed a fellowship and a collaborative clinic with the Department of Rheumatology. And I thought today we would spend time talking about that latter effort, in the hope that maybe some of the lessons that I learned over 15 years could be transported here to EVMS and be helpful. So I am probably going to go reasonably fast because dermatology is mainly a visual field. If I am going too fast, if you can't hear me, let me know. So what did we see in a Rheum Derm combined clinic? Well, there's actually a lot of different diagnoses. And I will again emphasize this is a Harvard connective tissue diseases clinic. And the only reason I emphasize that, you cannot refer to it here at EVMS. It does not exist yet. It may one day. But right now, this is really just historic, and I am happy to help you with any patients that you have. But the first thing that we did was we saw a lot of patients that really eluded diagnosis. So this chart actually shows you all of the diagnosis we saw in about the first 6 weeks. And it's a broad spectrum of diagnoses. The second basket of patients that we tended to see were patients that had a primary disease. It was one of the more traditional things that you would think about, lupus, scleroderma, dermatomyositis, but they had really recalcitrant disease, and their primary provider of care had put them on maximal therapy and still couldn't get it under control. So our job was really to try and get that under control. And then the third category of patients that we tended to see were ones that had common cutaneous complications of autoimmune connective tissue diseases, which is everything else on this list. Now, the reason I show this patient's photograph was this is one of our first patients from the clinic, and she came in with a list, and it had every single item on this list. So that was a very long visit. But today at Grand Rounds, I'm not going to try and talk to you about the entire 15 years. What I thought we would do was we would break it up. I would talk a little bit about collaborative clinics in general, very briefly, the kind of lessons that we learned, how we made it work in an efficient way. I'm going to then talk about what was the most common consult we got from medicine in that clinic and go over some basics of dermatological exam that can help. So maybe in the future, you won't even need to send me that consult. And then the third thing is things that we did in terms of research that really tried to push the field forward. So starting off with the collaborative clinics, are they useful? How can they be set up to optimize utility? So in academics, we really like to ask questions, and then we like to answer them. So we did try to answer this question. This was the first paper. There were about 3 papers that we wrote on this. This one really just looked at what we were doing. And all of them tried to answer the question, do combined specialty clinics add to care? And what we found was that even though all of the patients that were referred to our clinic had cutaneous manifestations, 95% of them had no therapy for that. Of them, even though most of them had rashes, only 5% of them had the rash documented, and only 6% of them had itch documented, and less than 1% got a specific therapy for that. And even in that 1%, the therapy was almost always antihistamines. And I'll come back to this, but unfortunately, antihistamines do not work for the itch of connective tissue diseases. 5% had no documentation of capillary nail folds, which is unfortunate because that can be prognostic as well as a disease marker. 0% had calcinosis or hair loss quantified before present, which meant that no one was really tracking it to know if it was getting better or worse. So we certainly were doing a lot of other documentation. Did we actually improve care? The subsequent paper to this proved that we did. We shortened the time to clearance for their skin. We actually addressed more problems that they had than they had prior, and our patient satisfaction scores were almost double what they were in the individual clinics. So they do contribute to the patient experience. And part of that is also because if you make patient care convenient to the patient, they take care of more of the things that are affecting them. If they have to go to 5 different doctor's visits, they're probably going to start making choices about which one to go to. So that is where I think the true value of combined care works. Growing a clinic doesn't happen overnight. So if you decide to do something like this, this is the number of patients I saw each week for the first year in an individual clinic. And so we started off at about 4 patients and at that stage, the dermatologists were sitting around going, well, we're not really doing anything. and my rheumatology colleagues were sitting around going, well, this is comfortable. We like this. And by the end of the year, we were seeing usually 12 to 14 patients in a 4-hour clinic. And the dermatologists were going, well, this is okay. And the rheumatologists were saying, kill me now, which I sympathize with. And part of the reason for that is anytime you do a combined clinic, you're going to have to do 2 sets of specialty exams, 2 sets of specialty histories, 2 sets of specialty discussions about the medicines, what you're seeing, how the other things that are interacting from the other specialty are going to be covered under the same thing. And so it lengthens the entire visit. So how did we get through this number of patients, and how did we make care so efficient? So this is not something that has to be just in combined clinics. You can also use it to make your own clinics more efficient. And that is, we came up with standard ways to document things. Once a patient was noted to have hair loss, for every visit, they would get a survey about hair loss. If they didn't fill it out, that's fine. We had iPods in the waiting room. They could fill it out there as well. Where possible, we use patient-reported outcome measures. And those are things that are actually already validated as scoring. So we know kind of how often we can send this to the patient, what kind of time interval is actually going to be meaningful for a change. And where not, we came up with our own. But the difference that this made is it moves a lot of the time that you spend in clinic talking to that patient, taking the history and typing into the computer. I hate this diagram because it makes it look like the patient's on the beach. I guess they are. But to the patient doing this at home, and this would automatically load into your notes. So all of the typing was done, all of the time of the history taking was gone. But there's more benefits than that. I mean, this is a paper from surgery, just so you don't have to be convinced just from my own papers, that they found that it made for a more thorough and efficient history taking. And we found the same. The different diagnoses were consistently documented in this way, which forced us to pay attention and see if they were actually getting better. We were able to develop visual, for the surgeons, it was visual recovery trajectory. They would look at what point, how many weeks after a knee surgery did the patient have ambulation and things. For us, it was, we were looking at how soon after methotrexate initiation should their skin rash be better. It was able to give the patients visual clues so that they could actually really be involved in the decision-making about their care and do patient-centered treatment. However, it wasn't just for the patient's benefit. We've all had patients come in and say to us, they don't know if they're any better. When you're doing these kinds of things, you can actually look at numbers and you can see if their itch scores go down. You can see if the frequency of their Raynaud's flares are decreasing. So that really gave you hard data in terms of seeing if the patient got better. It also did something invisible in that it treated more than just the patient sitting in front of you. And that's what I think is the true power of academic medicine, is that year after year, we accumulate standardized information on patients that have specifically well-documented diseases. And we're able to do studies on things like characterizing those diseases and evaluating therapies. And it's a way of doing research as an academic position that doesn't require you to have big grants, and it doesn't require you to do a lot of data collection. It just happens naturally with seeing the patients. So that's collaborative clinics and patient-reported outcome measures. I'm going to go on to the next bit, which is basics of common medicine derm consults. So this paper, as I mentioned, gave through all of these things, and these were the top consults. But when we really looked at what was the number one, it actually varied by the specialty. So for dermatologists, oftentimes they'd seen a patient and they had done a biopsy and it had come back with a differential and they'd sent an ANA. So the consult was, what does this ANA mean? Which always made me shudder, because I always feel like you shouldn't send a test unless you're going to follow up with it or you know what you're going to do with it. But nevertheless, this was our number one consult, but happy to help. The medicine one was, is this lupus? That was our number one question, most commonly about facial rashes. So what I thought might be helpful is if I went over some of this, the basics of dermatology for, is this lupus? Malar rash, this was one of my patients. This is lupus. This is a classic malar rash. In order to distinguish this, it's usually best to understand what other things you can confuse it with. So these are the top 4 things that were sent to us that we would be asked, is this lupus? And it wasn't. And the first 2 were pretty easy. The top one, This is a contact dermatitis. We can tell it's a contact dermatitis for a number of reasons. Oftentimes contact dermatitis, because it happens very acutely, they're very inflammatory. So if you think about things like poison ivy, where you get blisters or oozing, these tend to be exudative and very inflamed. They tend to be geometric. They reflect the thing that caused this. In this particular case, it's a mask. You can also get an id reaction. There's so much inflammation in that area that the cytokines travel around in the body and you start to get that same contact dermatitis rash in places that they have had contact dermatitis in the past. So where do we look for that? Most common locations for contact dermatitis, most common contactant is nickel. So we look at people's ears to see if they've got a contact from cheap jewelry. We look at their abdomens. Why do we look at their abdomens? Because that's where belts rub, which also have nickel in. Second one, we've all seen this in clinic. This is seborrheic dermatitis. It's not particularly a mystery. The scale tends to be oilier or greasier. It tends to go around the nasal labial folds. But you also have to look elsewhere. You look under the arms. You look at the back of the scalp. You look on the sternum. These are all areas where you're going to get seborrheic dermatitis. Once we get to the bottom two, it actually does become a little trickier. And these are ones that I even got dermatologists send them to me and say, is this lupus? So the first one is just plain old rosacea. But rosacea has lots of different subtypes. So if you've got rosacea like on the right here, where it is mainly papular and pustular, that's really obvious that it's not lupus, it's got pustules within it. But on the left is a little trickier. It's the erythematous telangiectatic subtype. And for this, that actually does distribute quite well in terms of the malar distribution. It has that same erythema and same telangiectasias as a lupus. You can look a little bit further. You can look at the forehead. You can look at the chin. Lupus tends not to go at least to the forehead. Other things you can do in terms of like ruling this out is history helps a lot with lupus. Things like sunshine and lupus flares are what flare lupus. Nothing else on this list really flares lupus. But with rosacea, they are often going to tell you, exercise, hot drinks, red wine. So history can certainly help you out. In dermatology clinic, occasionally we'll do this. We'll do a scraping on the patient's face. We'll come up with Demodex mites. They're on everyone's skin. It's what causes rosacea. If they have a huge amount of Demodex mites on their skin, then it's more than likely that it's rosacea that's causing it. And then we've come to this final one. And this is the trickiest one. And this is the one that it was pretty much evenly divided between dermatologists and medicine. So this is dermatomyositis. And sometimes these patients would even come in with a positive ANA, or maybe they come in with a skin biopsy that said, this is lupus. And why was that happening? Well, this paper answers that. What happened here is they took 10 biopsy specimens, each of dermatomyositis and lupus. They randomized them. There are only two diagnoses it could be. And they gave it to dermatopathologists who were experts in inflammatory conditions. And they asked them, is this dermatomyositis or is this lupus? And if they had tossed a coin, they should have got it right 50% of the time. And the result was about that. 11 out of 20 were correct. And this is not a knock on pathology. This is an emphasis of how hard it is to differentiate these two diagnoses under the microscope. So sometimes you'll get a broad differential, but sometimes it will say this is lupus. And the truth is they almost certainly could not tell. So that's why the clinical exam between lupus, if you're only going off of a facial rash, the clinical exam between lupus and dermatomyositis becomes critical. So I'm going to spend a couple of minutes on what the difference is, because there are key differences with this. Malar rash, the erythema goes down, but does not enter the nasal labial fold. That's as opposed to dermatomyositis, where it goes all the way down and into the nasal labial fold. The color is different. If you noticed with the lupus, it was usually a lighter pink. Dermatomyositis, it tends to have a little ruddier complexion, a little more vascular look. It looks a little more purple. Now, people tell me, oh, well, but rosacea can look like that, sun damage can look like that. That's true, but oftentimes you can see, if you look with a dermatoscope or ophthalmoscope at the skin, you'll often see that across the face. Whereas here in dermatomyositis, you often have a very strong gradient in the color. There are like other cutaneous clues. And this is why, if you send me a photograph and say, is this lupus? I will often say, I'd rather see the patient, because looking at other locations can really kind of like help a lot. So lupus gets rashes elsewhere. This is subacute cutaneous lupus. Oftentimes this is forming in rings, sometimes there's a psoriasiform version, but the scale as opposed to sebderm, which was oily, this is very dry scale. As opposed to dermatomyositis, again, notice the color difference. It's this ruddier look. Also, if you look at hands, you'll see that in dermatomyositis, rash goes over the joints, whereas in lupus, it's between the joints. Whilst we're on a dermatomyositis hand, you can look at the sides of the fingers. You'll often see something called mechanic's hands, which is a scaling that happens in that area. You can see these. These are actually key. This is actually 1 millimeter or sub 1 millimeter collections of calcinosis. It happens incredibly commonly in dermatomyositis. If you look at dermatomyositis patients' knuckles or their elbows or their knees, you'll often see these 1 millimeter formations, even if you don't see large ones. You virtually never see this in lupus. And then the other area is the nail folds. Even without magnifying this, you can see that there's some erythema, some redness there. And if you do magnify them, they look like this in dermatomyositis. They have these dilated blood vessels. They have areas of dropout where the blood vessels have burst. And in lupus, you will never get that. So this is the CME question. Every talk has to have a CME question. Mine was showing you what normal nail fold capillaroscopy looks like. And that's this top left. This is not my slide. This is from the ACR. I encourage you to look at the nail folds of all of your patients for the next 6 months, not because you're going to become experts in spotting the various stages of this, but if you've seen 6 months of things looking like that, and suddenly something like this turns up in your clinic, you'll at least know this is different. And, you know, repetition is the friend of recognition. So in scleroderma, it tends to go through a sequence. It goes from this normal, the normal in the top left, where it's thin, hairpin-like structures that align with the direction of the finger. They go to dilation and then dropout, where the blood vessels burst. And eventually you get to reangiogenesis, which is a little more chaotic. In dermatomyositis, they normally jump straight to this end picture. I've never seen a dermatomyositis patient, which is an intermediary. So this is a photograph from one of my clinics of one of my patients. And you might be saying, well, I don't carry around a $1,500 microscope in my pocket. You don't have to. This photograph was not taken with that. This photograph was taken with that. It cost $3 on Amazon. Your ophthalmoscopes are also just as effective. They have the same magnification as my dermatoscope. So for capillary nail folds, you don't need anything fancy. So this is the brief summary of the difference with lupus and dermatomyositis. Lupus, sparing the nasolabial folds, virtually never calcinosis or nail fold changes. Hands on between rashes between the joints is going to be light pink, scale would be dry and photodistributed. Dermatomyositis, pretty much the opposite, and hands often give big clues in terms of not just the rash distribution, but also the presence of calcinosis and capillary nail fold changes. So that is your speed lesson in dermatology of lupus versus dermatomyositis and its common mimickers. And I thought I'd spend the rest of the time just talking a little bit about things that we did in terms of research in this clinic. Now, the clinic was set up, anytime you do a clinic which has a special population, you are ideally set up for doing things like clinical trials and things. I'm not going to talk about any of that today. And the main reason is because all of that was planned. That takes additional effort up front. And what I'm trying to talk to you about today is really kind of like the serendipitous research that can happen just by setting up clinics with outcome measures and things. So all of these studies were not ones that I'm talking about today, are not ones that I actually planned. So we had all of these common consults, the clinic was growing, and then 2012, something miraculous happened, and that was that the referrals tripled. And I thought, oh, I'm becoming famous. But that was not what was going on. Because once I actually saw the patients, I realized that all of these additional referrals were for hair loss. And I thought, why? And the reason is the sleep criteria came out in 2012. There's new diagnostic criteria for lupus. And one of the things that was added was this number 4, non-scarring alopecia. And this confused a lot of people because dermatologists looked at it and said, well, that's pretty broad. We have scarring alopecias, we have non-scarring alopecias. Do all non-scarring alopecias count? Is this specifically lupus non-scarring alopecia? And the rheumatologist said, I don't know whether it's scarring or non-scarring. So that's why we suddenly got a huge influx of hair loss consults. And it actually became number 2 in terms of the reasons for referral to the clinic. So I always say, if you get a patient population enriched in a specific thing, that's the thing you should do research on, because that's the thing you've got data on. And obviously there were questions. The problem with doing hair loss is, I mean, any dermatologist, if you see your hair loss patient on your schedule, your heart sinks a little bit. And it's not because you don't want to treat it. It's because this is a really involved visit. There is so much that is on the exam, on the history, about what they're doing. There are so many different things that can cause hair loss. And in connective tissue disease in particular, there are a great many factors. So telogen effluvium, just a shedding of their hair, that would not count for the points on the criteria, but it does happen in lupus or dermatomyositis. It can be medication associated. Some of the medications we give, methotrexate, Plaquenil, cause hair loss. And then there are very specific changes of the hair that happen in lupus, which are not hair loss, but they happen in lupus, like lupus hairs. You can get co-occurring autoimmune diseases very commonly, things like lichen planopilaris or alopecia areata. So it's a very complicated workup that you have to do, and it takes a long time. This is an example of lupus hairs. This is one of the things that patients would come in and say, I'm having hair loss. Actually, their hairs they didn't have loss of density. They actually had just a change in the nature of the hairs. They become finer and twisted. This is another patient that was sent to me for hair loss. It was actually evaluated by a dermatologist and said to be alopecia areata. And I do understand why they said it was that, because it's circular. And when you look, there's no real erythema. The problem is when you look under dermoscopy, you actually see this. And what you're seeing, these are very classic characteristic follicular plugs. That doesn't happen in any type of hair loss apart from pretty much discoid lupus. This is a pathology of discoid lupus. You see the plugging there. So we studied this low rate of, this is one of the first studies we did on hair loss. We were trying to characterize it. We identified 252 patients with lupus and alopecia. We found only 70 of them were actually fully worked up. And of those, 61% were categorized clinically as having non-scarring alopecia, which left a large number of patients with unclear if it's 40% to 60%. And of those initially thought to be alopecia areata by a dermatologist, when we actually biopsied, we found that 10% yielded histopathological findings consistent with lupus, not alopecia areata. So there was a huge portion of these patients that weren't actually getting included in the diagnosis when they should have done. The other thing we did was we tried to characterize it. As I said, the SLIC criteria was very non-specific. And because we had a lot of these patients, just trying to map their patterns made sense, trying to give additional clues to people on what this should look like. So we did a retrospective review of our charts. We found that 36% of lupus patients had non-scarring alopecia at one point. And the reason that that's important is that is roughly twice the number of patients that knew they had hair loss, which made us then start doing hair density exams as part of this clinic, because if the patients don't even know they're having it, they can't alert you to that signal. And the reason that that's important is the next line, which is 20% had flares or hair loss with flares of systemic symptoms. And oftentimes the hair loss preceded the systemic symptoms. And so if you have a lupus patient and they're starting to have hair shedding, that means their immunosuppression is not sufficient, and they're probably going to have a flare. The other thing that we found was that 48% of these had diffuse patchy alopecia. Doesn't sound very interesting, but the reason it is interesting to us is that's a pretty unique form of hair loss. It doesn't happen in things like thyroid. It doesn't happen in things like androgenetic. It's actually the opposite of androgenetic. So when you saw this, you could pretty much associate it with lupus without even doing the biopsy. So that's hair loss. I'm going to pop back to capillary nail folds. As I said, again, this is the capillary nail fold that you would see. And nail fold changes weren't getting documented. Only about 5% of patients that had had this documented before they saw our clinic. But evaluation in nail folds leads to better patient care. And why do I say that? Well, studies, even outside of my own, this is ones from some rheumatologists who had looked at scleroderma patients. And what they found was that the density, as the density of the capillary nail folds went down, the risk of finger ulceration and lung fibrosis went up. So documenting that progression is important. There have also been studies that show that in juvenile dermatomyositis, capillary nail fold density is related to muscle damage or pulmonary function. So we agree that it's better for care, but why isn't it getting done therefore? Well, partially it's a skill that's not really taught that commonly. And in the connective tissue diseases clinic, we did teach residents and fellows to do this, but they were only with us a couple of weeks. And so unfortunately, that meant that they didn't always see characteristic signals. So what did we do about that? Well, this is a tip to anyone who's earlier in their research career. If you want to get funding for things, give it a fancy acronym. We came up with the ADVANCE project because we wanted funding for this, where we documented capillary nail folds and we imaged them. In 2011, we documented 4,680. 2012, this number doubled, and then it stayed at that doubled number for the next 15 years. So at this point, this is about the largest depository of these in the world. It's got around 200,000 capillary nail folds imaged. The reason for this was it captures the images and makes teaching possible. So in the same way that I showed you photographs of lupus rashes, I can now show you photographs of capillary nail fold changes. It also is a registry for future research and the importance of these changes. So I did a number of studies with this. I just talked to you about one of them. That's where we looked retrospectively at dermatomyositis patients. We were interested in adult dermatomyositis. Does it, like scleroderma, tell us about risk of comorbidities, or is it more like juvenile dermatomyositis where it might be useful to track disease? And the answer was neither of those. It did bifurcate, however, and it actually bifurcated in a way that we didn't expect, and it was actually based on treatment. So everyone started off with abnormal capillaries, and a subset of patients got down to normal capillaries. But it was based on what immunosuppression we were giving them. So if we give them prednisone, methotrexate, mycophenolate, or IVIG, their capillaries remained abnormal. Whereas when we give rituximab, they actually normalized within about 6 months. And this was interesting because what we think of those capillary changes in dermatomyositis is the same changes that are happening in capillaries in muscles and other organ systems. And so if we're normalizing the capillaries in the fingers, does that mean that rituximab is actually disease modifying in a way that other medications aren't? Now, this was an early study. We're still doing other studies to try and confirm this. But that was an interesting observation. And certainly in dermatology, it was notable because in dermatology, we've long believed that dermatomyositis of the skin component doesn't respond to rituximab. But the other thing that came out of my clinic was, because I was following patients that were on rituximab for their muscles, but they had decided that they didn't want to be on an additional thing like methotrexate for their skin, I followed patients' skin that were just using topical steroids. And, that led to an explanation of why the early studies of rituximab in dermatomyositis had not shown any changes for the skin. And that's because those studies lasted 3 months. We had based them off of psoriasis studies. And at 3 months, no change in the skin. When I followed these patients, I found that at 6 months, their skin did change. And so that changes fundamentally the way I manage patients that are already on rituximab for their muscles. In that oftentimes, if they want their skin changed, I will put them on something like methotrexate or mycophenolate mofetil. But at 6 months, I'm now going to taper them off of that. So I'm going to be able to minimize their therapy. So it has changed the way in which I use those medications. Primary skin disease recalcitrant therapy. This one was a huge part of my academic productivity. The reason being, a lot of the reason that people had recalcitrant therapy was we would then go on to discover that they actually had paraneoplastic disease. It makes it much more complicated to treat. We're limited in the medications we can give them. They often have their disease being driven by something underneath. It raises questions about what screening did you what methods of screening? How often do you do this? I'm not going to talk about dermatomyositis because we would be here for an hour if that's what I was going to talk about. I'll talk about scleroderma. A lot of people tend not to think of scleroderma as being paraneoplastic. We looked at scleroderma patients between 2000 and 2017, excluded overlap diagnosis in skin cancers. And what we found was that there was a huge spike right at the time of diagnosis of RNA polymerase III scleroderma with underlying malignancy. And this has been repeated at other institutions as well. This is not novel in that way. The risk is roughly 5 years around the time of diagnosis. And fortunately, the type of cancer that usually drove it was breast cancer. And I say fortunately because it means you don't have to think about it, because this is usually part of their age-appropriate screenings. The only point that you have to think about is, are they up to date with their age-appropriate screenings? And if they're not, you have to make sure that they are. But it's not like dermatomyositis where we have to start reinventing the wheel in terms of when screenings are appropriate and what is appropriate. Itch is all the way down the bottom. It's the least common referral we got, but it was actually the one that was most important to patients because it's the symptom that bothered them. They didn't necessarily care about some of the other things, but itch really kept them up at night. So we did a number of studies on itch. This was one of the ones where we retrospectively reviewed them. We were able to look at distribution of itch, timing relative to disease. We were able to characterize it by giving different levels of itch and distribution in different diseases. This is just showing dermatomyositis much itchier than lupus. Does that matter? Probably not, unless you're trying to make that diagnosis. It can be helpful. But the thing that was helpful from this paper was that we were able to show differences in the degree, the time of onset, and the effectiveness of different therapies in itch in the different disorders. So I commented earlier about antihistamines not being terribly effective in this for itch. In lupus and dermatomyositis, it was often a problem of inflammation, and so increasing their immunosuppression was necessary to suppress that itch. And it was usually an early stage of disease that they got it in. In scleroderma and Sjogren's, it was not usually early disease they got this in, it was late disease, and it was always due to the changes that didn't happen to the skin, the scarring that had occurred or the loss of moisture. And so then it was about skin repair. It wasn't about immunosuppression, or it was about neurological medications. And we developed a therapeutic ladder to help people with that. Calcinosis cutis. I am going to fly through these slides a little, but this has been something that's been very important to me also, partly because I love things that don't have any treatments, and this is one of them. This is one of my patient's knees with a large deposit of calcium on it. Why treat it? It's not harmful. Well, the problem is calcinosis significantly retards ulcer healing. If you get calcinosis within it, it can be very painful. This is one of my patients that was a guitar player. Calcinosis comes up at areas of trauma. So as he played his guitar, he developed calcinosis in the tips of his finger. That was his career, and because it's painful, he can no longer play, so he can no longer work. And then it also causes pain if it happens. This is one of my patients. This is not a corn. This is calcinosis in the bottom of the foot. Every patient that has this tells me the same story. It feels like walking on broken glass. And it does, because it's literally crystals of calcium in the bottom of their foot. So one of the things you can do is you can destroy them, all kinds of surgical interventions. You can vibrate them. You can use lasers. You can cut them out. The problem is, as I said, calcinosis happens at areas of trauma, and surgery is in itself a form of trauma. And so there's a very high risk of recurrence there. And therefore, that can lead to a lot of morbidity. This is one of my patients with calcinosis of the fingertip right there. She did have this removed against my advice, and she ended up losing the entire finger. If you're still eating, you might want to look away for the next few slides. Dermatologists generally don't worry so much about this. This is that patient on the first slide with calcinosis on the knee. This is her a day after surgery. She's not got an infection. It looks infected, I agree, but it's not infected. What's happened is she's got a foreign body reaction here. This is very common. It happens at virtually every single time someone has a calcinosis removed because they leave tiny fragments of the calcium in there. It's impossible to get it all. She had other sites done. This is, I think, the elbow, and it went on and calcified and dehisced and did not heal. I will come back to this patient. Medical treatments for calcinosis cutis, many medical treatments suggested. Some are designed to interfere with calcium pathways. Some of them are about immunosuppression, reducing inflammation. Some have very unclear mechanisms. I'm not sure why they would work, but they do have one thing in common, and that's that they don't work. At most, they slow the calcium accumulation. They certainly don't treat the calcium which the patient has come into you with. And it's not just me that says this. This is a paper out of Mayo where they looked at it. I'll walk you through this table. CR is complete response. If you look down that column, pretty much zeros all the way down. There are a couple of case reports. The only thing that's really giving a significant signal in terms of complete response was surgery. And I talked to the authors of this, and they had high rates of recurrence. Diltiazem, the reason I highlight that is that was the most common medication that was given at their institution for this. It is the most common medication that is given at MGH for it. And in complete response, 0 patients. For no response, 5 patients. So you're already doing pretty poorly. Partial response was 9 out of 17. You might take some hope from that, except for the fact that this was actually not partial response in terms of being meaningful to the patient. This was after 5 years of therapy, because that was the duration. 5 years of therapy of being on diltiazem. The patient said, it might be a little bit better. Most patients are not going to do 5 years of diltiazem for that. So we started doing intradermal injections of sodium thiosulfate. We were the first place that actually started doing this. Sodium thiosulfate had previously been used for calciphylaxis, mainly used in IV. It does make some electrolyte shifts, kind of hypertension, and it requires slow infusion. And in calciphylaxis, it makes sense to give it IV because the calcium is in the blood vessels. So it's getting right where the pathology is. In calcinosis, that doesn't make sense. It doesn't really work because the calcium is in the tissue, not in the blood vessels. So we did a couple of papers about this. This was the first one on topical sodium thiosulfate. We looked at over 600 calcinosis lesions, 100 patients. And what we found was that the effectiveness varied with size. Under about 2 millimeters, which sounds small, but if you're walking on cut glass, that's significant to the patient. 100% effectiveness within about 3 weeks. We could get all the way up to 5 millimeters, but it varied with the orientation of the lesion. So if it was 5 millimeters across the surface of the skin, we could treat it. If it was 5 millimeters deep into the skin, topicals didn't work. So to give you examples of that, this is that first patient. It is gone at 3 weeks later. I'll give you a slightly more convincing photograph. You can see the telangiectasias on this patient's finger. So you know this is the same patient, even though the orientation is a little different. That is the calcinosis. That was the 5 millimeter one. And then it's gone 3 weeks later with topical sodium thiosulfate. That led us to how do we get to those deeper lesions? Intradermal sodium thiosulfate. We treated 116 calcinosis cutis lesions in this particular paper. Everything up to 2 centimeters, we could get 100% response. Now, I will say under 5 millimeters, that was one injection. Between 5 millimeters and 2 centimeters, that's a series of injections spaced over weeks. That's why I've separated them out like that. Above 2 centimeters, 0% complete response, which is disappointing, except for the fact that it did have partial response as indicated by reduction in size, reduction in discomfort, and healing of the overlying skin ulceration. So in other words, all things that were actually meaningful to the patients. So this is that patient who was the guitar player. This is him, and this is one injection. 3 weeks later, he's able to work again. So a huge difference to his life. I said I would come back to this patient. The excisions, what do we do for them now? Because I used to not advise excisions. This patient, we injected sodium thiosulfate into her wound base. We also did all of the wound dressings soaked in sodium thiosulfate, and we were able to get this to finally heal. And so if patients do have excisions, I will try and work with the surgeon to have them do this as part of the postoperative therapy, because otherwise the healing is horrific. Erythromelalgia, I have just this last study to talk about. And why would I talk about erythromelalgia in a clinic designed for connective tissue diseases, because it's not necessarily what I think of that we would have been treating. And the reason is serendipity. This paper will tell you the example why, where we characterized all the patients we kept getting sent for small fiber polyneuropathy. And we looked at all of the clinical features. And two of the clinical features was new onset Raynaud's and edema of the hands, which is an early sign of scleroderma. So that's where all of these referrals came from. But then we ended up with a huge population of these patients. And because we were characterizing them, we were able to do some of the first papers that really kind of looked in depth of what their cutaneous manifestations were. And then we did this later paper on it where we looked at their response to therapies. And we were able to, because we were doing biopsies that looked at the density of their nerves, we were able to show that in early disease, where the nerves are largely intact, the anti-inflammatory and immunosuppressive medications often helped their symptoms. But in later disease, once the nerve density had dropped, you really had to turn to neurological medications to help them. So this is a picture of me at MGH. It just shows that, this is not just my work. It is a work of a team. I ran a derm room fellowship. We ended up training many derm room fellows over the years. They went back to be leaders. One of them is one of the leading connective tissue disease experts in Saudi Arabia at this point. We trained people from Brazil. We trained people across the US. We also trained room fellows who came and rotated with us. We generated a new generation of dermatologists. And some of the rheumatology fellows were even people that trained with us and decided to work with us. So that was very rewarding. So when I started this talk, I said I was going to do a talk about clinical insights from a combined derm room clinic. And I hope I've shown you that it's not just a talk about derm room or combined clinics, that really this is about how to get clinical insights from clinics in general, because all of these techniques are transferable to other types of clinics. And I can say that with confidence because I was the chief of the clinic, and so I was able to help other people set up clinics this way. And I actually co-authored with over 30 of the Harvard faculty, both in dermatology and outside of dermatology, setting up clinics this way so that they could look at their disease processes that were they were interested in. So I hope this has inspired you to do clinical care. I hope it's helped you a little bit with understanding what lupus looks like. I hope that it's given you some ideas about your own clinics. If you have any interest in combined clinics with dermatology, I'm always open to that. It's not just me. We have other faculty who are on board or joining this summer. If anyone has any questions or help with patients, I'm happy to be available to help you. And with that, I will say thank you for your time.
Questions? Please go ahead.
Thank you very much for that question. Open the doors of perception. We know that a small fiber neuropathy often presents with itch. I just wonder how many of your skin lesions and connective tissue diseases were neurodermatitis rather than disease affecting the skin.
Yeah, so we did look at that. So when we were trying to characterize the patients that were dermatomyositis and lupus, a lot of times it really was in early disease that it was an inflammatory component. In later disease, and specifically, especially with Sjogren's and scleroderma, we got a significant number of patients who did go on to develop small fiber polyneuropathy, and we would look specifically at the density of the nerves in those patients. But it is a subset. And usually what the clinical ladder that I referred to was about was these are what the primary disease you're treating, how to address the itch in those patients. And if you have residual itch or you're having zero response to that, this is the workup that you would then go into in terms of small fiber polyneuropathy and trying to advance those therapies.
Thank you. Dr. Benson, please.
In your patients with dermatomyositis, and in particular those with nail fold changes, and in your study, did you notice that there was any correlation between the development of these capillary nail fold changes and their subsequent development of pulmonary hypertension?
So we looked at a number of other factors. It was a different paper that we did. We did not find that because I really was looking for other comorbidities that were related to this because, you know, anything that was vascular, whether it was kind of changes in their lung or their hypertension, etc., we didn't have that. But it might be that we just had too small a number. I mean, dermatomyositis is not a common disease, and this speaks actually to some of the other studies that I did in terms of like malignancy screenings, you know. I at one point thought it would be a really wonderful idea to have this prospective study to look at kind of malignancies and what screening, the impact of different screening approaches. But when I did the power calculations for this, I found that I needed more than about 5 to 10 times the number of dermatomyositis patients in the US to be doing it. And not all of them come to see me. So it may be a power issue, but we didn't actually see that as an association.
It's interesting because we have used rituximab in some of our patients with scleroderma-related pulmonary hypertension and dermatomyositis and lupus-related pulmonary hypertension with some success.
Yeah. No, it's a very interesting link, and that's part of the reason that I was saying, like, this is an intriguing finding, because although we didn't prove that next step association, the theory is, you know, those small capillary changes you're seeing here are happening in the other organ systems.
If I may ask a question about, registry that you started.
Yes.
I guess early on as your clinic was, and if you can expand a little bit on and sort of, for faculty and for residents to sort of help them that what process was and what the thinking process was, how you sort of put that together, and any changes that happened over time. And it looks like quite a few papers came out of that, the data collection registry process.
Yeah, so the reason I wanted to talk about the serendipitous data collection was because it's the way to do research without so much funding or effort. When I set up the original clinics, it's because that's the way I thought. You mentioned I was a physicist. That's the way I think. It's like I like to be able to come in to see the patient the next time and be able to compare them to what they were the last time. And so I like to have very standardized things where possible. We looked for patient-reported outcome measures as one of the things. They're not patient-reported outcome measures for everything. So some of them we had to develop ourselves. Some of them we went to subspecialty societies for. And every time we started to see things like the hair loss increase, we suddenly would incorporate that into the collection of data. If they had a complaint in that clinic, we looked for something to track that complaint with, and then it would trigger. Epic is very good at this. As long as you have the diagnosis in there, it can actually be set to send these to your patients. It's part of the reason I wanted to give this specific talk, because we've just gone through the transition to Epic, and I'd like to think that there is some benefit to all of us in terms of like our clinical care. But the original setup of the registry was really about documenting kind of like how their diagnosis was made and including that in the information, because if you don't have very clear-cut diagnoses, your studies become messy as well. So it does take a little bit more time at the startup, but it does accumulate over time. I don't know if that answers your question.
Yeah, that's great too. So who does data collection? Is it physician? Is it nursing staff? Is it patients that is given a questionnaire and they fill and complete it? Is it research associates, students, residents?
So it depends how much data loss you're willing to accept. Okay, so to me, research shouldn't stand in the way of clinical care. Clinical care should be the priority. And so what we would do is we would set patients up, we would send them to these surveys to them through the patient portal. About 20% of the time they would do them. They would show up in our clinic. It shows on the check-in whether they've done all of the assigned questionnaires or not. And if they hadn't, they would be given an iPad. And if they did it during the wait to see us, great. If they didn't, I would usually spend 5 minutes going over one of the surveys with them. Over time, because the patients keep coming back to you, they learn how to do this. And honestly, it ends up with a long-term patient They're doing all these surveys. They know how to do it. They know it's part of the visit. They've seen the graphs that result from it. They've seen their own itch scores go down, their own pain scores. They're excited to know how it is. So they actually get a lot out of doing this. So usually we don't need to incorporate that much administrative or research fellows or anything like this. This is really part of their clinical care.
Thank you.
We have a question from the virtual audience.
Hi, Dr. Smith. This is Aditi. Thank you so much for your talk. This was great. I was wondering if you've had any luck with trying topical sodium thiosulfate for calcinosis cutis?
Yes. So we did a couple of papers on that. Topical sodium thiosulfate. We compounded 1-to-1 with vehicle, the vehicle being whatever their favorite moisturizer was, because I didn't want to give them a contact allergy. And it varied with size. It varied with size with every formulation of sodium thiosulfate we used. For topicals, it usually worked 100% effectively up to about 2 millimeters, which doesn't sound very large, but that can make a huge difference if it's somewhere critical, like a fingertip or a bottom of the foot. For lesions larger than that, it depended on the dimension. So if they were horizontal to the surface of the skin, you could get up to about 5 millimeters would melt away. If it had depth component to it, you had to go to intradermal injections.
Got it. That was my experience as well, and I was just wondering what you had thought about it.
There's not many other treatments for them other than having like surgery or something. And as I said, surgery has lots of comorbidities, and they're probably going to end up using sodium thiosulfate even after the surgery. So it is my favorite intervention.
Thank
Dr.
you.
Patel is a rheumatology faculty. Go ahead, please.
I've already spoken to him about a combined clinic way before any of this, but I'm really excited to see this. So thank you.
Thank you.
Hi, I just want to preface this by saying I'm an M1, so I really appreciate what you've stated. So let me know if any of this is incorrect. I wanted to ask about the nail changes in Raynaud's phenomenon, because I know that like in lupus, and I even think the dermatomyositis, that you could possibly get Raynaud's phenomenon. Do you see that confounds any of the capillaries and the nail changes at all?
No. So the capillary nail fold changes really are about the vasculature. And so though in Raynaud's therapy, oftentimes their vasculature is hyperreactive, you don't tend to see disorganization in those capillary nail folds simply from Raynaud's. And the classic connective tissue disease that has lots of Raynaud's is lupus, and it's the one that actually has the least amount of capillary nail fold changes. You can find them, but not on the kinds of things that we're using in clinic. Usually you have to actually use much higher intensity magnifications and things. And so my data set does have some of that, but it's not something that I use clinically. It's more of a research tool. Thank you for the question.
All right. Well, thank you. Thank you very much, Dr. Smith.
Thank you for having me.